name is Vijay, and I am the client partner at Nalasha Health, and I'll be your host for this webinar today. And I can see people from across time zones have joined. So I know it's early for some of us. So firstly, I'd like to thank all of you for joining us today for this webinar. After handling a dozen certifications, we have planned this educational webinar to help you understand the requirements for Medicaid MU3 2018. So we all know that we are running against an aggressive timeline ever since the CMS announced the last updates. So today we will cover the concise overview of managing CMS test procedures and their updates, key decisions to optimize your MIPS quality score, documentation of self-declaration measures. Also, we will focus on why performance improvement and the QPP strategy go hand in hand. To make this webinar more interactive, during the session, we will have a few polls in between for all the attendees. And I would request all of you to answer them so that we have an understanding about where each one of you stands with respect to this new standard. I'd just like to draw your attention to the GoToWebinar panel onto your right-hand side of your screen, uh, because during the course of the presentation, we would only be taking questions through the chat window that you see on the GoToWebinar panel, where you can type your question and send it over to us. We will be sure to get that answered either immediately or towards the end of the session. Post the presentation, we have planned a 10-minute Q&A session where an attendee who has a question will have to click on the hand icon, which is on the top left side of the GoToWebinar panel below the mute button. We will unmute the attendee and you can go ahead and ask your question, which will be answered by our speaker. As the purpose of the webinar is to present the details of MU3, and this is not a discussion, we will have all the attendees on mute and will be unmuted only during the Q&A session if you raise your hand and have a question. All right, so I would like to introduce our speaker of today. That's Anuj, who is our presenter and speaker for the day. He is the subject matter expert for US healthcare at Nalasha Health, and he has been working in the healthcare sector for more than 15 years now and has worked throughout the entire ecosystem. He has worked closely with a number of healthcare software solution providers and also the government testing laboratories to have solutions get certified and stay compliant. All right, so grab your coffee, sit back, and I hope all of you have a meaningful session and in the end have some takeaway from this webinar, which will help your plans around the endeavor that we all need to go through in the coming months. Over to you, Anuj. The floor is yours.
Thanks, Vijay, for the introduction. As introduced, my name is Anuj, and I work as a subject matter expert with Nalasha Healthcare Solutions. So, in today's presentation, we will look at various quality payment program, attestation requirements, which are tricky, and tips to qualify for them in a more meaningful and with less issues in the implementation and the certification phase. So starting with our starting with the Qpp overview, in 2015, and most of you may already know about this, but for some of you who would like to reconfirm the MIPS-MACRA laws, so in 2015, the Medicare Access and the CHIPS Reauthorization Act was signed into law, repealing the Sustainable Growth Rate Payment System, which was also called as SGR, which governed how physicians and other clinicians are paid under Medicare Part B. MACRA effectively replaces the fee-for-service reimbursement model into two tracks. One is the merit-based incentive payment system, abbreviated as MIPS, and the other one is the Advanced Alternative Payment Model System, abbreviated as AAPMs. We'll talk about AAPMs and other innovative clinical models in the latter half of the webinar. Now, focusing on MIPS, the scoring system, as you know, MIPS is a score-based system, rather a yes or no system, which we used to have during our meaningful use stage 2. So the scoring system is on a scale of 0 to 100, and the score will impact how the CMS calculates the payments effectively after 2 years or trailing 2 years. A good score in 2017 means a payment positive payment adjustment in 2019, and so on. The MIPS score will be used to calculate the payment adjustments on a sliding scale from a 4% positive or 4% negative based on your 2017 scores, which will be paid in 2019. This will be ramped up to plus and minus 9% scores in 2020 and 2022. So both the positive adjustments and the negative adjustments will increase on the either side of the scale. The payment adjustments will be on a linear scale, so every point earned will mean a larger reimbursement. Now, as you must be seeing on the slide, the MIPS eligible clinicians include physicians, assistants, nurse specialists, and nurse practitioners who bill Medicare more than $90,000 annually and see more than 200 Medicare patients. MIPS is basically split into four categories on your left. Advancing Care Information, or ACI, which carries a weightage of 25% and replaces the Meaningful Use Stage 2 EHR incentive program for Medicare. The program remains the same, the Meaningful Use program remains the same for Medicaid. However, now for Medicare, it comes under the MIPS umbrella. The Quality, which are CQMs, and replaces PQRS and carries a weightage of 60% this year and 50% from next year. And the third one is the Improvement Activities, which carries a weightage of 15% and in which you may have to choose at least 4 improvement activities related to clinical or patient engagement workflow. And the last one is the Cost, which has a 0% weightage for the current year, and CMS will build the data based on the 2017 claims received, and in the subsequent years it will carry a weightage of 10%, which will be pulled out of the 60% we have for quality. In the next, we'll talk about what we call as the big 3 standards. So I'm sorry. So as per our analysis, working with various EHR vendors, we can comfortably say that in every implementation, the weightage of interoperability related criteria has been more than 60%. 3 major interoperability components in stage 3, and they were actually existing in stage 2. 2 of them were actually existing in stage 2, are CCDAs, CQMs, and the new one is the API access. It is necessary that design and development of these 3 major criteria are done in the early phase rather than later, as these criteria comes with workflow dependencies which can adversely impact your timelines. Now, talking first about CCDA, which includes generation, consumption, viewing, downloading, and transmitting the information electronically and automatically as a part of your workflow, is an important component in both EHR and patient portals. Since CCDA is a template-based standard and will be subsequently upgraded, it already did upgrade from 1.1 to 2.1, from MU Stage 2 to MU Stage 3, and its design shall consider a platform-independent solution. Just because it's a standard and it may subsequently upgrade as well. So it should be platform-independent, configurable, extensible, so that you don't have to rewrite, and it is easily pluggable component to your EHRs, to your patient portal, to your CCDA delivery mechanism through API access, or whatever peripheral applications you may build, which are sharing the patient data in a standard and normalized manner. Now, just talking about few experiences we had with some of our clients who did their own MU Stage 2 and they came to us for Stage 3 certification. We found that few of them really had no way of rewriting or maybe extending the templates of CCDA, because the development was embedded within the EHR and hence whatever changes they make in that program of the CCDAs, and for even the next standards it is applicable, it eventually led them to rewrite some of the code, change it, do a complete round of regression because there was an impact on the EHR functionality. So that's where we see that these standards are configure are something which should be pluggable and loosely coupled with your system rather being an integral part of your solutions, because this will change and then upgrading them will destabilize your certified version of the EHR. The second one is the clinical quality measures, which means QRDA files for patients which are category 1, and the summary files which are also called as category 3. Also includes performance dashboard related criteria, the export, the import, and the filters related criteria. Just like CCDA, QRDAs are also prone to template changes, version upgrades, and CQM's module which you will bring should also be pluggable, loosely coupled, modular component, which is not embedded into your EHR code base and can be easily upgraded to potentially meet or add new templates into it. The third one is the API access, which is a newcomer in the stage 3 certification, which includes opening up the EHRs to outside world in such a way that minimal integration is required to consume data from your EHR from either party. Though meaningful use does not mandate the standard, but we, based on our experiences, have recommended our clients to consider FHIR as a standard for your API implementation, as it inherently solves the specific standardization, the integration, and security issues, which are basic considerations of API design. So these we call as our big three, which should be your primary focus in the design phase. Okay, next we will talk about the suggestions and the workflow improvements along with some of the security and the documentation requirements and the focus it needs to be able to successfully certify for the meaningful use stage 3. So the feedback driven system, as most of you would be already aware about the decision support system, because you may have created the clinical decision support criteria or qualified for it in the stage 2 requirement. It is important to understand the importance of the decision support system, and just not in just meeting the certification needs, but also the role which it can play in increasing the performance of the providers. Now, linking the decision support rules to various quality measures, which will help your provider to remember the steps they might have skipped while providing the care at the point of time. It will also add to the consistency, given the same type of care provided by different providers in a respective agencies. Providers can review feedback from decision support system, which can help them complete steps before closing or signing off patient chart, or however you would like to design it in your workflow. Similarly, the standardized treatment protocols or treatment rules or clinical care rules can be set up, which can help standardize practices that they want to treat their patient with respect to standard situations or clinical parameters. For example, when a patient comes in and you have not evaluated the smoking status of the patient, let's say, then it may just put an alert that while you are checking in the patient, not checking in so as to say, but maybe when the provider meets the patient and starts typing the chart, it can be a part of your template as well, where you will write the clinical notes. But if it is not filled in, then this can also be one of the potential alerts which they will get, that hey, you have please try to fill in the social history. And in case he is a daily smoker, then a prescription of a smoking cessation or whatever education you may like to provide can also be triggered using these rules in your feedback-based system. Another great tool of patient engagement is patient portal. We are already aware about it because it has stood through and being continuously extended in requirements based on meaningful use stage 1, stage 2, and stage 3. So collecting feedback through the patient portal, and by feedback, I mean the feedback from the patient by doing surveys regarding their visits, regarding their experience in the practice, and what can improve in both the quality of care and in terms of easing the appointments or whatever they, the facing part of the practices, and even to improve the quality of care which they receive will make not even your patients more happier because you care, but also will increase the performance score in the QPP as it is one of the important improvement activity QPP proposes. So one of the 4 improvement activities, couple of them are related to engagement and feedback surveys, which you can uh, elaborate on. Next, we will talk about focusing on the standardization of the data. So you should be able to build elaborate dictionaries or standard vocabularies in your system because, as I told you, more than 60% of the certified EHR criteria are related to interoperability, and interoperability needs a standard. So getting away from normalized text to something which is more structured is a requirement in stage 2 and is being more further pursued in stage 3 as well. So development of a standard vocabulary system which supports various standards including SNOMED, ICDs, you may be already doing ICDs a lot, CPTs, and even the mapping between SNOMEDs and ICDs and other types of codes are very important with respect to giving these away in CCDAs and calculations required in CQMs. This also means that you will have to upgrade these vocabularies because they come with the extension of the vocabulary system like every year or every second year. And then how to upgrade your systems in such a way that it does not create a downtime for your customers and can be easily upgraded without much impact is also an important consideration to make. So talking about the provision for better provider scoring, we should keep in mind that every provider may not fare well in every measure which you may have created in the EHR. So we should let the providers choose the measure they will like to submit the data for based on the measures which match their caregiving approach. Letting them choose a high performance or high priority or outcome based measures will further help them to score better due to the bonus weightage they carry in the QPP scoring system. Simple workflows to share data with patient health agencies like immunization registries, specialized registries, state registries, and third-party clinical registries will also help providers score more, as most of these measures have bonus weightage in QPP score. The last point about the care coordination is also an important point, and we'll talk more about it in the subsequent part of our webinar. Now, providing the specialized, monitored, and coordinated care for high-risk patients will further help them, help the providers as both an improvement activity, because it is, again, one of those 15% carrying weightage activity, and also will help providers perform better in their risk contracts, which they may be signing risk-based contracts with the private insurances as well. And a proper coordinated care will help there as well. Next, we'll look at the security and the document consideration and the challenges which we face during the certification. From the security point of view, which is on the left-hand side of the screen, we need to understand that the objective one of the meaningful use stage 3 does not completely cover all the aspects of HIPAA laws uh, which are required for covered entities, and EHR is a covered entity by HIPAA. For instance, while the objective one of MU3 is just limited to annually conducting or reviewing a security risk and adopting risk management strategies that are sufficient to reduce the vulnerabilities to the confidentiality of ePHI maintained in the certified EHR. However, from the perspective of HIPAA, we need to understand that it is just not the data which resides in the EHR, but also the providers, the users which interact with them, and the workflow they use in creating those documentation, importing the scanned files of the patient, exporting the data out across the complete arena of the workflow they are using for patient care. The ePHI, we already know there are strict security concerns around it, and hence the transmission of such information to or through the third-party systems like patient portal, CCDAs, and direct messaging API shall be carefully analyzed for the risk it poses, and the mitigation strategies for the same should be well documented. As an example, for instance, MU3 now requires patient portal to also support sending unsecured mails to providers or any email address of their choice, just to be flexible for them to be easily able to send the CCDAs or the clinical information. But any communication going from unsecured channels through your systems, which may be patient portal, will be coming under security scanner, and proper risk mitigations and documentations and policies needs to be framed in case the adverse happens. Similarly, any storage done by the EHR concerning ePHI, especially which may remain in client machines. So next, we have on the right-hand side is the documentation part, which is also an important thing for MU stage 3, and it has gone more extensive with the time from stage 2 to stage 3. Many of us overlook the documentation till the last minute or start with it during the certification waves. This is a potential risk since MU3 demands lengthy and proper documentation, which may be publicly available as well for your providers to make the right choices while selecting the EHR. Any wrong or inaccurate information in documentation puts your organization into risk of being penalized or audited if any of such information is not found to be true or existing. Hence, the documentation phase shall start earlier and should be done during the implementation and the QA phases. We suggest identification and documentation of gap measures and the identification of WCAG level A or level AA conformance, whichever you may choose, during the design phase. WCAG requirement is an input to developers and QA due to its technical nature, and hence we suggest our clients to start that phase while in the design phase so that these information can be an input to the next phase, which is the implementation phase. In the implementation phase, we suggest you to complete all pending documentations from design phase, which you may have already started, along with documentation for attestation of self-declared measures. As all the measures are not tested anymore, you must be aware about the updates which came around October last year. Not all the measures will need to be demonstrated to the proctor. So that creates, that is good in some ways because it saves you time during the certification, but it is challenging as well because now you have to create elaborate documentation or the self-attestation documentation, which is very accurate, complete, and any changes in the screens which you are going to put there will further trigger you to inform the respective agencies that this workflow has changed and that may need another round of documentation. Finally, in the QA phase, we suggest to completely map all the QMS protocols in your respective organization to an ISO or an IEC standard and document the same as MU3 requires now, and MU2 was flexible about it, but MU3 requires all your QMS policies to map them to federal standards, and any deviation will need proper reasoning and documentation why a deviation happens. Now, QMS is also an input to your QA processes, so you would like to start it and nail it down before the formal QA testing starts. Post QA phase, UAT testing shall be performed with at least 10 clinical or non-clinical users, and their usability testing report shall be converted into safety enhanced documentation, which is again quite elaborate and time consuming. And also need your UAT users from the who may be the clinical users and their feedback in the safety enhanced design documentation. Finally, prior to the certification, you will have documentations to complete for the measures, because many measures do depend on them. One of them is the privacy and security, along with any pending documentation which shall be completed to avoid any delays post certification. Now, having said that, one piece of the information which is on the left-hand side also is significant on the right-hand side of the documentation. The API and the API security both needs to be well documented, because this will be the contract for the public API which you will put, which each of your integrator will follow. So this needs to be quite elaborate, quite understanding, just like you would create a training guide or user guides. This will be a technical guide for the developers to be able to extract the data out of your API and the steps they need to follow to be able to talk to your API. Okay, in the next, we will speak more about how to manage certification and the ways to accelerate your certification during the certification phase and from the implementation phase to the certification phase as well. So this is more concerning towards managing the certification. Once you have your dates scheduled and you're going for certification, much of these exercises should start from the QA phases, which includes preloading the test data. This will include any data which you may have already got from your proctor or the NIST data, along with any data which you may get de-identified, PHI data which you may get, because it will help your system to test against the actual data which it will see at the time of production. Now this is an important point, as one of the instances which I recollect is that we did a lot of UAT on the CMS test data, and we were not aware about the sensitivity of CCDAs with the special characters. And once we put the system into production, there was some data which came into the system which had special characters into it. And once we got that prior data into our new system, our CCDAs began to invalidate. So these are some important things which you should keep in mind to actually do some testing with the real data, but obviously de-identified data. Now, conducting internal mocks from time to time, and at least one before your certification wave, is also important. During the certification, during the documentation, you should avoid time during the certification for doing documentation, which we have already spoken about in the prior slides. Share documents for review, which would mean that any documentation you would have already prepared based on our suggestions you should be able to give to them prior to the certification wave to the EHR, so that they can provide you any feedback or anything which is pending with respect to a measure. And once you demonstrate that successfully, that measure is actually off your list. Um, Talking about the test scripts, basically the testing tools as well. You should have proper regression test steps in place, because as part of certifications, you may see that your development team may make changes after UAT, after QA phases, or even during the certification, you may need to do some tweaks as per the provider's feedback. So there should be quick scripts which you can run to see that if there is any impact on the system, so that you can have a stable system on the day of certification. The thing also applies to the tools which you use. There are many things to keep in mind regarding upgrading the tools version. Like, for an example, you would use Cypress for QRDA testing. You would use the DCDT tools for the direct messaging testing and for CCDA validators. Now, these tools are third-party tools. They are not in your control. So it is good that you test your system well and see how these tools behave, and are ready to also test it before you move to the certification wave to see if there is anything which is a cause of worry. Many of these tools can also fail on the day of certification, or they may be offline, or they may not be performing well. So you should have an alternate path in mind as well if any of these third-party dependencies uh, bothers you during the certification phase. Um, Talking about the certification wave itself, we suggest following the test scripts and the guidelines or the proctor sheets which you will be getting, and not displaying some other workflows or the workflows which you would have developed because of the needs of the system or the user experience. Uh, so we suggest our clients to remain targeted to the certification needs and only demonstrate the flow which is required to meet that certification. That saves you time and does not confuse the proctor unnecessarily, because he has so many things to check in the given point of time. We have also seen that proctors may go beyond test scripts to actually look at few things which may be borderline test cases, negative test cases. So if you get caught in one of those challenges, don't be surprised. Many of them, many of our EHR system, we have seen that pattern based on the proctor as well. Some of the certification and negative test scenarios which are not part of certification can also be looked at. So you should be just aware about it. Next, we'll see the ways to accelerate uh, in the whole life cycle of your development. We have already seen much of this before and spoken about it. So moving on to the ways to accelerate. So certification is just getting the EHR. So before I talk about that, basically we have already discussed about planning and focus on the design and standards, and you should be more focused on both the Medicare and the Medicaid programs requirements within the planning phase itself, because there may be some requirements. You may have providers both from Medicare and Medicaid, so you may try to get both the birds with the same bullet. So that said, you may be finding a good intersection points about what requirements you should be doing as part of your certification criteria, so that you can actually get both your Medicare and the Medicaid providers in line based with the same EHR. So identifying those are really good things. We have seen that some of the clients go to the implementation phase, spend some time there, and then say, no, this is not making much sense for our providers, and it will anyways not lead to any score in QPP. So we can go, we can just ignore it for now and we can take another measure. Now, this is costly during the time of implementation. So whatever changes, mitigations you would like to do the identification of the requirement and which you are going to certify for is important in the planning phase. Finalize partners, communicate with them, and analyze the integration effort. These partners mainly refer to the third-party systems. You may be using one for e-prescription if you are not building your own SureScripts module, or you may be using another patient portal. You may be using a direct messaging protocol, or any such thing. You should be able to identify what are the third-party systems you are going to go right in the planning phase rather than later, and then analyze what is the cost, integration effort, and how much your providers will need to pay more because of you going with that and the long-term plan around it. Chalking out workflows for providers, again, to sit with your users before you go for the implementation, to ask them what workflow they actually follow and what will be more adaptable so that you can tweak the meaningful use requirements and marry it with the actual provider's user experience, and the workflows can be more targeted, are important things which you should keep in mind during the planning phase. Moving on to the implementation phase, we have already spoken about developing the major components, especially the big threes, and then work on to the dependent ones, because many of these measures do take data or give data to these interoperability standards, and doing that latter may pose another risk of you missing an element which is required in CCDA, and you may have altogether missed it. And once you do the CCDA in the latter phases, you'll realize, oh, I needed this element in the demographics information. Then you have to go back and change your demographic screens. So this is an important point with respect to the implementation, handling the dependencies better, and initiate the security, quality, and attestation documentation during this phase, as we have spoken about. And it is good to engage with your proctors as well, get your first certification wave dates, and basically engage with them with respect to what all criteria you are going to do certify for in the first wave and second wave and third wave, and plan that the complexities are well balanced between the three waves, and you are keeping the last wave lighter. So all of this should be done well ahead in time while you are in the implementation phase. Moving into the testing and certification phase, we suggest a dry run with all your third-party systems, because like e-prescription, we had to get our e-prescription vendors, design team, or the business analysts on call so that they can demonstrate some internal workflows, which is not part of our EHR, but is the integral part which needs to be demonstrated in the stage 3 certification. So you should be well ahead in terms of doing dry runs with them and even calling them in your certification day, because you may need them around that time. Plan each wave separately, as I have already spoken about, and perform any code merges to avoid go live delays before the certification. Preparing training documentation, especially along the third-party tools as well, and the usage of it and your EHR is an important thing which you should complete before moving to certification or during the certification phase, just because we have seen that EHRs do get successfully certified, but it takes a lot of time to get to the customers and production, and so you can actually narrow down those so that your certification times and production times, there's not a big gap between it. You should also train your providers for the third-party systems which you may have. Certification is just getting your EHR onboarded with, with minimum CHRT qualification required to participate in MIPS. However, providers need to report data on same platform and demonstrate performance. So that is the reporting part where all the payment adjustments are kicking in. So CMS will be working to benchmark quality measures as per the data received in 2017 and 18 years. And similar benchmarks will need to be pushed into the EHR as well for the providers to know their targets. So even if you have providers who are eligible for MIPS, you should also understand that they may be eligible in AAPMs as well. Or they may not be eligible in MIPS, but they may be doing AAPMs or other innovative models of care like comprehensive primary care plus or patient-centered medical home PCMH. So some of the participants who want to enroll to AAPMs or these other innovative care models, you should also, you will be also, or you should be also keep them in consideration because they may be your EHR users, which are either not coming in MIPS umbrella or actually want to go to these innovative care models so that because it helps them to both get the 5% incentive on the Medicare Part B payments and also claim an exemption from MIPS. So they may not be required to do all those things which you are required to do in a broader MIPS umbrella, and it may be suited to some of your customers as well. So adoption of MIPS or AAPMs, the use of the certified EHR is still must. So here is where we see that the EHRs must cater themselves just not to the MIPS providers, but also make a system which is able to help their providers taking a certain AAPMs if they qualify for it. Next, we'll move to the value-based care, is preparing yourself to pay for performance model. That's what QPP is helping you to do. Patient engagement and identifying variance in care in the similar care patterns and tweak workflows accordingly are some important considerations you would like to make after the certification. In fact, the fourth category in MIPS score, which has a weightage of 10%, is cost, which in 2017 has zero weightage because CMS will be compiling the data. But next year or 2018 year reporting, you will be seeing the 10% weightage coming in. So this essentially means that CMS is going to determine the variance in cost with the same quality of care received based on the claims which have been submitted as part of the quality reporting claims data. This will mean a practice to be able to define an episode group and assign cost to each group and attributing these groups to one or more clinicians and then asking them to kind of follow the cost assignment within that episode group so that you're not overdoing the claims or you're not overdoing the cost part for providing the similar quality of care than the benchmarks. So this is something interesting which we may see can be designed into the EHR to be able to call out the episode groups and assign costs around it so that that similar quality of care and the type of care provided actually meet similar claims and costing mechanisms as well. Additionally, care coordination through identification of care plan goals and standardized interventions and protocols required to meet those goals will need to be also devised and planned ahead. This will also involve identifying patients based on the clinical parameters and to be able to outreach them so that you can close the care plan gaps or monitor their high-risk patients and close any gaps in care which you may have to perform well in the value-based care model. For care coordination or the value-based care model to actually succeed, data is the key. And data may be available from encounters, claims, CCDAs, revenue cycle management systems, and it can all be tied into a population health portal, which can help you identify the patients which need care, and you may be able to contact them, outreach them, and then ask them to close care gaps. One of the examples may be like every breast cancer screening, which is also a HEDIS measure, or I think it's also a CQM measure, but whether you have performed breast cancer screening for your patients every second year for women who are greater than 58 years of age. So that said, if you are seeing a patient, you don't have to wait at the point of time when they are actually coming to you. Rather than you will have a system which will tell you that we do not see any visit or any information from the patient claims or the encounters that they have gone through a breast cancer screening, or we don't have that in our record. So that will be good to identify that patient, to be able to outreach them and call them and say, hey, did you get your breast cancer screening done? If not, it's good to have it done. So these type of things you will be able to identify, and population health will really help you in focusing on preventive care and value-based care model. In the next slide, we'll more talk about what do we have with respect to the capabilities. A system would require to be able to meet these future demands, which we just spoke about, to increase the performance, get the population health, the value-based care model fit in. So we have broken down the capabilities into administrative, clinical, and financial areas. From the perspective of getting the data across the system and getting the data from disparate sources, you would need a master patient indexing system, because each of these systems will have their own patient data with their own identifiers. So you would like to avoid duplicates and be able to consolidate that data into one patient. So getting an EMPI module into your system to meet any data warehousing needs or ETL needs, or to get the data together, is one of the important part of identification of patient. Smart forms, including auto notes, including creating templates which are more prone to the clinical workflows, and allowing your users to be able to fill in the notes in a structured format is also one of key areas which will add to both the user experience and to the capability of your system to properly manage documentation. Qpp dashboard scoring will be an evolving thing. The scores might change, the weightage might change, so you may have to tweak your dashboards around it. So that is also one of the configurable component, I would say, which you would need to further work on for the next 5 years. Any patient engagement mobile applications, tools which you would use to help your patient push the data from the system, from the patient portal to EHR. We normally see that even meaningful use stage 3 mostly talks about getting the data to the patient portal. I mean, it's mostly one way, or rather, if you're not doing improvement activities where you're also taking the feedbacks and surveys, but also you may be taking some data from the patient which is available, or which they may be having, like calculation of few vitals like blood pressures or any glucose readings, or maybe the number of steps they do and the exercise they do for the obese patient. So all of these things can be gathered right from the patient portal into your EHR, which will also increase your patient engagement and data gathering from the patient. Care planning module, which is more standardized. We had a very simple care plan module in stage 2, which got enhanced into more structured care plan requirements in stage 3, but were optional. And so many of us didn't do it. And because creating a CCDA in the care plan domain is a challenge, because much of the data is not that much standardized around it. So having that system built up, which caters to a care plan, which can be easily communicated through a care plan CCDA, or can be easily communicated when the patient transitions from one provider to another, are important things which can be made so that similar care and care plans can be migrated with the patient as well. Interventions and the care plan goal settings are also important considerations which this will entail. Telemedicine, you must be already aware about, is gathering a lot of traction, where you can see patients and reduce the load on your providers by having some offline encounters available to the patient with the nurse practitioners or with the doctors who can do telemedicine. Care coordination module using population health, which I spoke about before, is also one of the important consideration, along with the Internet of Things, because we have got the various devices sending the data to us. So this also fits in the concept of Internet of Things, where you will be able to get the data from these specific devices and be able to read it and be able to upload it to the portals or patient portals and then take it into the EHR. Into the financials, we can build up FHIR APIs, which are more financial domain concerned. We can leverage FHIR in that area as far as the standardization is concerned. We can also do population health to meet the financial dashboards, etc., which will give you more information around that, how to manage the finances of the practice or how to perform well in your financials using the data which you have in hand, along with the artificial intelligence and the machine learning. EDI 7030 is a future mandated requirement which you will have to work with if you have an RCM system. So these are some important capabilities which we see coming into EHRs or as peripheral modular systems in the EHR, which it is going to evolve in the next 5 years.
Well, thank you, Anuj, for walking us through the presentation and sharing the information. All right, as mentioned earlier, we have the Q&A session now. Okay, I see Philip has a question. So Philip, I'm going to unmute you now. You can go ahead and ask your question.
Hello, Anuj. This is Phil. So I wanted to understand, what should I expect in MU3 regarding safety enhanced design?
Okay, yeah, that's a good question. Basically, safety enhanced design as part of the MU3 entails there is a checklist which your proctors will be providing it to you. Now, this is an input to your UAT testing and can also be an input to your QA testing. But anyways, QA test cases will be more elaborate than the UAT test cases. But you will get a checklist, and and the checklist will be for the dependent measures. I think A1, A2, A3, A4 until A14, and some of the criteria in B category also qualify for it, and it's required to complete safety enhanced design documentation around it. So what you will do is you will take these checklists to at least 10 non-clinical and clinical users, and you would need the feedback from at least 10 of them as per the stage 3 requirements, and then put that how much was the success rate and as many times they would have done that testing, was it passing or was it failing, and these are the minimal user test cases which you will get to fill in, which will your proctor will provide some part of it, and you are required to additionally put your user acceptance test cases which your users would have tested in addition to what is given to you. So all of that should be submitted in an elaborate checklist along with the attestation document about the safety enhanced design documentation. So this is what should entail in your MU3.
Okay, so while you were answering, Anuj, I could see another hand being raised. I guess it is Steve. So Steve, I'll go ahead and unmute you. You can go ahead and ask your question.
Hey there, this is Steve. Well, how many QMs are required to qualify for QPP, and how much more score can I expect if it's less than required amount?
So I think you're asking about how many clinical quality measures, right? ECQMs are required for QPP.
That's right.
Yeah. So for QPP, the minimum number of quality measures is 6. And as far you are doing at least 6 measures, you are good. But with the 2017 data requirements, which you should have already attested by now, 31st March is the last date for it, for all the data of 2017, which you're going to report till 31st March, even if you submit one measure, you should be good to not get any negative penalty. But having said that, if you are able to increase your score more by submitting more than 1 to 2 or 3 measures, then, or at least 6 measures, which is also a QPP requirement henceforth, you will go into the area of positive adjustment. So we have seen that submitting 6 files with one outcome will give you a score of 35 to 40 in the current context of 2017 reporting. In 2018, however, the 6 quality measures are the requirement, and you should at least have your EHRs do those 6 measures. But as we said earlier, you should also look at the dimension of doing several categories of clinical quality measures, which your providers may be successful in their day-to-day activities to adhere to those, and then let them choose the ones where they perform well for better score. So that should answer your question here.
All right, so I guess those were the only 2 questions. Thank you, Anuj. So thank you everyone for your time and patiently observing the shared content, and a recorded version of this webinar will be available on our website soon. And we will be sure to share a link with all the attendees. You can reach out to us if you have any questions or clarifications, and we will get back to each one of you personally and have those answered. Thanks once again. We would be glad to hear back from you. Have a good evening, and bye everybody.